My name is Vijaya. I'm going to talk about clinical coding and also HRG. Some of you might already know what is clinical coding and HRG. Can I check if anybody knows? No? So I will elaborate on this. It's going to be a great help for you, not just for now, in future, when you go to become consultants. There's quite a lot of background info that happens once you document in the clinical record. Let's go. So what is clinical coding? Well, the description is there, you can read, but in simple words, we translate whatever you write in the clinical record into a meaningful coded format. So it's quite crucial how you write, what you write. And it's also quite important how we translate into a meaningful code. So we follow World Health Organization provided books for diagnostic coding. There are 3 volumes, one for index and one is this, a tabular list. And we also follow these OPCS books for procedures. This is local, but this one for the diagnostic coding is used worldwide. And so I'm going to show you what it can be used once we code. So some of you might do a clinical audit later on. One of the consultant might ask you to get how we have done with the NOFs or any fixation or anything like that. You submit a query to information department, and then they will give you all the patients relating to that diagnosis. They get all that information from the coded information. So this is useful for, from the coded information, you get the payments for the hospitals. And there's, they can measure how the disease spread. And for example, if they want to check how many COVIDs we had at EST. So they extract all that data from the coded information. Just wanted to give you an idea about how a payment is determined once the patient comes into the hospital, once they're discharged. My team gets the notes, either it is online when it is in a scanned form or a physical notes, and we allocate all the codes necessary. And then depending on the diagnostic codes and all other relevant comorbidities they have, like diabetes or hypertension or anything else, and also what kind of procedure they had it done, and also whether they went to ITU or is it a general ward, and depending on how many days they stayed within that environment. And also the payment system also takes into consideration their age, whether they are children or adult or things like that. And also if the procedure is elective, there is a different price. And if they come in as an emergency, it's a different price. So the system takes into all consideration and creates a HRG code. That HRG code has a price tag. That's how we get paid for the activity that comes to any hospital. Any of you aware of this before? Does this mean important to you? No? So this is how the payment, I'm going to take you a little bit further to one other slide, why it is important to input all the comorbidities they have. So now with the updated HRG, the HRG code is the code here. It is a 5-character code. It always starts with 2 characters, 2 letters, and there are 2 numbers and a letter. Each body system has a different letter that starts with. And suppose if a stroke patient comes with no comorbid, no other conditions, and then we will get an income of, depending on whether it's mostly non-elective, it will come in as an emergency as stroke, but they determine this because there will be surgical patients, some may be elective. That's why they created this kind of table. And also there is, you can see there is a trim point. That means they are expected to stay that many days, and we are supposed to treat them within that time period. So every condition had a trim point set. And all this is measured behind the scenes. Once we code and submit the data, everything is analyzed. How many days we took to treat each patient? How complex is that patient? And the healthcare analytics will determine how well we are treating, whether we are prolonging their stay, whether we are treating them within that time frame. For each day, we get the 266 pounds for every day they stay. So this is how the payments are determined. I'm just going to take a little bit back. We learned about how it is paid. So the HRGs, as I said, they were non-existent prior to 2006. So the National Case Mix Office, it is a part of NHS Digital. They develop and they improve every year. And since 2017, they improved it to a HRG 4+. So prior to 2017, there was only 3 different bands of payments, like for a major condition, for intermediate condition, and a condition with no comorbidities. But now, as I said in the other slide, there are 5 different categories. Depending on the complexity of the patient, you get more payment. At the moment, only our elective activity is payment by results. All the non-elective activity, we have a block payment we get from CCGs. Now I shouldn't be saying CCGs, now they are demolished. Now it is called ICBs, Integrated Care Boards. So that's how we get paid. Each hospital gets paid. So there used to be a limited number. Every year they keep adding. They improve as we develop new procedures. So the HRG numbers will change, and also the diagnostic code numbers also might increase depending on the new diseases that comes out. For example, when COVID came out, we didn't have a code to put what code to use. So we have the NHS Digital released a code that can be used from our extended category. And then we were getting questions about what if they are COVID, but it's not confirmed by lab results. Then they have to give out another code like that. And then when Zika virus came, they gave out one other emergency code like that. The codes might increase depending on the new emergence of diseases. And also procedures, as we invent new procedures every year, there might be a new procedure, and we have every year some other added codes to OPCS also. So with the new HRGs, it gives a greater granularity, and it impacts on our incomes that we receive from ICBs. Is it still not making any sense? No? So you might be interested how it will impact on our HSMR, SHIMI. Does anybody know what HSMR is? Yeah. Yeah, hospital summary mortality rate, that is. And SHIMI, and Rami, all these, if we code all the complex conditions, they are expected, their likelihood of dying is more than if we don't add all the conditions they have. So it is why I'm mentioning all this is quite important to document everything, every condition a patient have. What we come across is sometimes they are on drugs like statin or metformin. We know what I mean, any layman will know what a statin is for, but never documented that they are hypercholesteremia or things like that. So it is quite important to document everything in the case notes. I understand patient care is more important, but when you have a chance, um, it's important to document everything. I know your side of the story. I'm only non-clinical member in the family, so I have consultants, ST6, and core surgical training all in the family. So I understand your struggles and your time pressures also. So this is how our shimmy is. Prior to 2000, I started here 2016, and we were reliant on quite a lot of agency coders, and our depth of coding wasn't great. So the red line is our peers. We are always compared with our peers who provide the similar conditions, similar facilities in different hospitals. So we are always, as long as we are below that red line, we are okay. As soon as we are going across that red line, the medical director and chief executive will get letters and emails from CQC and saying what's happening in your trust. Quite a lot of patients are dying when they come with simple conditions. So it is quite important, which is why also it is important to document clearly. So we've just shown a little bit about how we can get more if we document well and if we record well. This is another one with hip fractures or knee procedures. So if they come non-trauma, if they come with trauma, there will be a different price. So every condition, so the condition and the treatment that take similar resources are grouped into one HRG code. Does anybody know about Charleston's code? No? So Mary Charleston, she's professor of internal medicine in New York. She invented this score in 1987, I think. Our healthcare analytics people, or just tell you a little bit background about that. So once we code all the activity, we have about 11 to 12,000 inpatient episodes every month. So for all the July activity, we are supposed to be completing our coding and submit all the data by 15th of August. Every month, middle of the month, we have deadline to reach all the previous month's coding. Once we submit the data to SAS, that's secondary user services, and then they submit that data to HES. Does anybody know about HES? Hospital episode statistics. That's where all the hospitals data goes to. And then the healthcare analytics people like Dr. Foster and CHKS, they analyze all the data and produce the results. So they take into consideration also how many patients have all these recorded conditions. If they have, as you can see, if they are 50 plus, the score is different. And if you are 60, over 60, the score increases, multiplies, and then so on. So if the people, if the diseased patients have one of these conditions and the score is high, they think that hospital is trying and treating trying whatever they can to treat the patients. And in the end, they couldn't save if they have all these conditions. So the likelihood of them dying is more if they have these conditions. So it's quite important to, not to omit these if you come across a patient that have these conditions. Also, just to give you an idea, like every little detail makes a difference. So the comorbidities have a score from 0 to 2. Sometimes it might alter depending on the main condition treated. So the diabetes, CKD, and all that. It's also important to if they are in retention or things like that. So as you can see how we can score the comorbidities. Not we, the healthcare analytics people rate them, score them. So just wanted to give you how we code. This is our encoder. Suppose a patient came in to give you a bit more on the previous slides I showed you. So they came in with stroke and just hypertension, and the HRG here. The system generates, once we say complete, the system generates a HRG code here. As you can see, it's a stroke with the CC score 0 to 3. And if they had any procedures done, we code them here. If they had catheter or CBP line, or if they're given clot busting drugs, alteplase and all that, we can code them in the procedure side. So this is how we got the payment, and the payments also differs from the previous year to year depending on the circumstances and the health economics going on behind the scenes. And the system also applies a market forces factor. Each hospital have its own market forces factor depending on the costs, running costs and the staffing costs. So suppose if the hospital is struggling to appoint full-time staff and they're reliant on agency staff, so our expenses are high, then the market forces will be high. So they add all that when we are getting final payment. So the same condition, I wanted to show how it will change if they have many other conditions. So this patient have many other like CCF and acute renal failure, and the next one also so all these conditions a patient have, and then it generated the other HRG with stroke with CC scores 16 plus, and then the payment will be totally different as you have seen in the previous slides. So the key thing is to document, and document. That's all we request from you. I know you do quite a lot of initial clerking, which is why I wanted to show why it is so important to document everything. So all the comorbidities, and just have something to add here. So if they are medically fit for discharge, it's quite important if you add that, and there are some hindrances for them to go home, some care arrangements or whatever. If you add that in the notes, we can add a certain code that improves the payments we receive. And also we need to get this right for the data quality, for the complexity of the patient to get it right. And if they are immobile, it's quite important. You might think that it is not a medical condition, but we might be using a hoist and all that to move them. So it's quite important to So whatever minor detail a patient have, it is important to document. And so when they have incontinence of urine or feces, we might be changing bedding. All the nursing care is quite a lot, the number of times and all that. So it is quite important. And also when you write cholesterol high, like arrow, or thyroid, so and so figure, and arrow down and things like that, we are, by following coding rules, we are not supposed to take those into consideration. It is good if you can write hypercholesteremia, hypothyroid, or things like that. If you can elaborate and write clearly, that will help us. Also, there you can see approach when you're doing a procedure or things like that, what kind of approach and what kind of assistance like CT or things like that, if those codes can be added as well. So if they have taken biopsy or things like that, if there are different codes for shave biopsy or punch biopsy, or not just mention biopsy is done, if you can specify a bit more, we can code accordingly. So all we request from you is a clear diagnosis. I know, I understand sometimes it is not possible. If it is not possible, then we just record the symptoms they came in with. So if you can give us a clear diagnosis, uh, uh, and also the words you use, possible, likely, if you say that, then we can't use that and code that condition. So that those are the coding rules set by NHS Digital. So it has to be written as probable, treated as, things like that. So if you can name, suppose if they have UTI or things like that, it would E. coli or whatever grown. My team also checks the path system. We also check the radiology, what actually done, sometimes CT, different areas, how many areas, and all that. We also look into those systems to to code accurately. I know it is a bit boring topic compared to fracture knob, but it is going to be useful for you guys to understand what goes behind the scenes a little bit more and why we are asking you to document everything. And sometimes you just say a condition, we don't know whether it is acute or chronic or things like that. If you can elaborate, and we get PAF, there is different code for if it is paroxysmal, persistent, or permanent, things like that. If you can elaborate, that will be great. Do you think it is any useful? Yeah. Any questions?